Yeah, I'm sorry that the abdominal pain ones haven't, some of you aren't able to open the abdominal pain ones, but I'm going to open it now. It may take a couple of seconds while I do that. And if that's going to be the case, I'm going to open a couple more in the background so that we don't have any delays between cases. Okay, that's taking a while to load up.
It's Iman, it's recommended you can only open one at a time, one viewer at a time, so you can't tab like that.
Okay, one viewer at a time. Okay, fine. Okay, so let's have a look at this one. So I want to look at the plain film first. So let's go for the plain film. And so most of the time when you're doing this plain film x-ray, obviously feel free to throw in your answers. A young person with abdominal pain. Oh yeah, so someone said Ollie's disease. Yeah, you're right. Okay, good, with that previous case. Okay, so with this one, we have got someone who's come in with abdominal pain. And so usually when you are, yeah, well done. So when you are looking at abdominal films, first of all, you do want to look at the bowel gas pattern. You want to see whether there's any dilatation of the bowel. And when we say dilatation of the bowel, you're looking at air-filled bowel dilatation, because if it was fluid-filled, you won't be able to see that. So when you're reporting no evidence of obstruction, if you are reporting radiographer or a radiologist or a registrar, what I encourage you to do is to use the phrase no air-filled bowel obstruction is identified, because you cannot rule out where there's fluid-filled bowel obstruction. Because I have plenty of cases where it looks completely normal on the abdominal film. You do the CT and there's multiple loops of dilated small bowel all over the place. But in this particular situation, you can actually see multiple loops of small bowel and large bowel. The large bowel is sitting all around like so on the outside, and in the central area you're going to have the small bowel, and none of it looks particularly dilated, but a few people have already spotted, well done, that there seems to be what looks like a mass effect. Everything's kind of pushed away, right? So what should be happening is that you've got all the large bowel on the outside, and in the middle you just got all this small bowel. But in this particular image, you can feel like there is a bit of a mass effect, kind of everything pushing upwards like so. So at the very least, you should be able to say that there seems to be what looks like a bit of a mass coming from somewhere, and more likely to be coming from what looks like the right side of the abdomen. Obviously, you've got other shadows to be looking at. You've got your liver, you've got your spleen over here, you've got your gallbladder over here, you've got your kidneys over here. So and then you've got urinary bladder over here quite centrally. But this mass appears to be slightly different. It doesn't seem to be coming from those kind of approximate areas that you'd expect the normal anatomy to be. So if your normal anatomy doesn't conform to what this lesion is, then you've got to start thinking about what else this could be. So something in the pelvis. This patient is a female patient, which I probably should have mentioned. So this could either be a uterine lesion or it could be a uterine lesion. It could be an adnexal lesion, i.e. ovaries. And obviously being in the right iliac fossa, it could also be something like an appendix that could be coming up. Quite unusual for an appendix to be this big, but I suppose if you do have an appendiceal tumor, that kind of thing, then yes, you could be looking at an appendiceal lesion. Now, for those of you that are quite eagle-eyed, you can see that yes, there is, well done, there is what looks like a calcification sitting within there. So when you've got calcification sitting within what looks like a pelvic mass, again, yeah, you're right. Someone may say, well, you know, you could get fecalist material. Fecalist material sitting within the appendix can get calcified, so you can get an appendicitis or an appendix abnormality that has got calcification with it. Other things that can have calcifications, obviously you can get calcifications of lymph nodes, all right? That could be previous TB, it could be ongoing sarcoidosis, it could be, I think you can get calcified lymph nodes in when someone has non-pasteurized milk as well over time, and obviously previous infection. And the other thing that can happen is you get desmoid tumors as well. So desmoid tumors where you get sort of calcification, so you get desmoplastic reaction, and then you get calcification of some of the mesentery, and then ends up getting this kind of clumpy calcification. Some of the bowel gets pulled towards it. And when you get bowel pulls towards something, usually you would end up getting bowel obstruction. In this situation, yes, we do have a calcification, but we don't have a anything else, nothing looking like anything being pulled towards it as well. So at the moment, all we have is what looks like a mass, and we also look what looks like we've got a calcified density. Not much more we can say beyond that, and a few people have thrown a few differentials. Maybe you've jumped onto CT, which is fine, which is great. If you haven't, you know, you've got some good differentials there, so yeah, that's good. Iliac bone infarct, yeah, I guess it could be. I mean, you could say that, but then in the absence, if you had just had that sitting by itself and nothing else going on, then yeah, you know, you may say to yourself, this could be an iliac bone infarct. Oh, one more thing it could be is a renal calculus. But renal calculi tend to be in line with the ureter, which, yeah, you could say it could be, but it doesn't seem, it's not usually so clumpy and circular. So it's very, very circular in appearance, whereas renal calculi don't tend to be as big as this. And if they are, they're normally kind of thin and cylindrical, not so clumpy like this as well. So yes, at the moment we've got, so when you've got a lesion like this with an associated, what looks like a mass effect coming from the pelvis, there's only really one thing that it could be, but I'm going to go to the CT to show you. So let's go from the very, very top. What I'm going to do is just download that in the background. So for those who don't use Collector Minds, if you are using it, you can actually use the little cloud button sitting here to sort of speed things up, and hopefully things will be a bit smoother. So abdominal pain can happen for a few different reasons in any patient. Obviously, cholecystitis could be one, but we did see something abnormal in the lower abdomen. But just to show you, this is the gallbladder, and that looks completely normal. What phase is this? This is a portovenous phase because the aorta doesn't look as bright as the vertebra. It looks almost the same kind of density as the portovenous system. And actually, the portovenous system over here looks slightly brighter. So this is more likely to be a portovenous image. And they're coming through. This one does have a few calculi. Can you see that? If we kind of scroll through, you can see the circular density sitting over here. And, you know, when you actually, this is quite a good point. So, you know, you can't see that calculus on the X-ray because actually it's not a calcified calculus, but on CT, you can see that calculus. But even on CT, sometimes you don't see that calculus because it's not actually that heavily calcified. Sometimes you get cholesterol calculi, which are not visible on CT and on X-ray. Right, the other thing that can be causing abdominal pain is going to be the pancreas, but the pancreas, this fluffy looking thing sitting right down the center of the abdomen, looks completely normal as well. So that doesn't look like anything to worry about. And remember, we're saying, could this be a renal calculus? So we're looking to see whether there's any evidence of any hydronephrosis, which would look like Mickey Mouse hands, but this doesn't look like a Mickey Mouse hand on either side. Both kidneys actually look pretty normal. And the ureter, which is sitting over here, looks fairly normal as we scroll all the way down. So if we kind of scroll all the way down, you can hopefully see that big mass. But the actual urinary bladder and the ureters actually look normal on both sides. But now what we see is this huge looking mass sitting within this region, right? So we've got a huge mass sitting within that region. And as someone said, where there's fat within that liver, I wouldn't call fat on this liver based on this image. Obviously, this is a non-contrast study, but as far as I've read, if there's anything less than 40 Hounsfield units, then you've got to go with steatosis. And if you were to measure that, it wouldn't be a less than 40. And generally speaking, you'd usually want to do a non-contrast study if you're going to be investigating fat infiltration. The gallbladder calculus is there, but it's not causing any abnormalities or any sort of compromise at this present time. So, yeah, so well done. So yes, this is a female patient. And you can see that there is a uterus sitting over here, and you can see this very, very large lesion sitting over here. But, you know, what you want to do is sort of make sure that you are 100%, you know exactly what this lesion is. And so you've got to kind of make sure you go through this case properly. So you could say, look, I think it's teratoma, which you're fine, you know, you may be right, but how do I 100% know that this is not an appendiceal lesion? And the only way to really do that is to go through the bowel, right? So I always say the constants are going to be the descending and the ascending colon on either side. So this is the descending colon. They're pretty much always going to be there. You know, they don't really move. The sigmoid colon can go for a walk. The cecal pole can go for a walk. The transverse colon can go up and down all over the place. But generally speaking, the descending and the ascending colon on both sides of the abdomen stay the same. So if you're ever lost, go for those sides. So on this particular occasion, I'm going to go for the descending colon. You can see the bowel going right across the front like so. Now we're at the hepatic flexure. We're going all the way down, all the way down, all the way down. And you can see that this is a cecal pole sitting over here, but we can't really see a connection between the cecal pole and this lesion, right? And then you can see this kind of area, this tubular structure coming from this area over here and finishing. Can you see that? That one there coming this way, this way, this way, this way. It feels like it finishes, doesn't go anywhere else. So that could be the appendix. But again, the point is we can't see a connection between the bowel and this lesion that is sitting over here. So that's kind of, again, yeah, saying, okay, we don't think this is a bowel lesion. I don't think this is appendicitis. I reckon this is something else. And people have already said, so this looks like an adnexal lesion, an ovarian lesion. But what kind of lesion is it? When you look at this, you've got a few varying densities sitting within this lesion. You've got you've got a bit of a higher density, you've got a bit of lower density sitting over here, almost fat-like, you know, when you're looking at the two. But more importantly, you've got these sort of hyper-dense material sitting over here. If we go to the bone windows, which is going to be the clincher, hopefully, you can see that doesn't look, that looks like a tooth. And there's only one reason anyone would have a tooth within the abdomen, unless they swallowed one. It's because, exactly right, you can see that looks like a tooth, doesn't it? Sitting within the abdomen. Only one reason, exactly right. Well done, a teratoma. So yeah, you can say, well done, you've got teratoma. Is that all we should be worried about? Well, the thing is, people can have teratomas and have no symptoms whatsoever. But if you've got a patient that's got symptoms and they've got a teratoma, and actually when you look in this region, look at the fat that is sitting over here. Can you see that? Compared to the fat that's sitting over here, it looks like there's a bit of inflammation going on. This doesn't look quite right. And a young patient has come in with what looks like a large teratoma and a bit of fat stranding located within the pelvis. You have to be worried that this patient may actually have something known as a torsion. So what can happen is you've got the fallopian tube and it can actually become twisted on itself, start to cause issues. And so this patient needs to go to the gynecology team as soon as possible, because they're going to be clearly in trouble. There's going to be some compromise, and obviously long-term implications could be death, and obviously less than death could be infertility as a result of significant torsion. So yeah, that could be the cause of pain. So yes, teratomas, you can find them incidentally, but in a context of someone who's got pain, you got to take a little bit more seriously and basically, send them off to be seen by the surgeons.